Hi and welcome to another video from the CTAD Clinic. My name is Dr. Mike Lloyd and I'm the Clinic Director. In the video today we're going to be looking at a question that is posed when we talk about complex trauma, and that is of its sort of component part, which is simple trauma. So we think of this in terms of complex PTSD and simple PTSD. Now we understand what we mean by this, but what I wanted to clarify today is that simple PTSD in the way that we're using it does not mean what some people might think it actually means. When we talk about simple PTSD, we're talking about single event trauma, whereas complex PTSD is often multiple event trauma. So these are things that can take place over a long period of time, quite sustained, quite regular, quite frequent, occur over a long period of time. And that's the stuff that we often see underpinning the more complex levels of dissociation as a symptom later on in life. Whereas with simple PTSD, we simply refer to it as an event that leads to PTSD. So it's the event that has a singular type, acute, one-off type cause. That's what we mean by simple. The actual presence of PTSD and the components of PTSD are anything but simple. They are vast, and often the degree to which people become distressed and disorientated and disabled by PTSD are massive in terms of the effect of that person on just everyday functioning and their life and the way that they see the world, and it can last for many, many years. And PTSD is something that can absolutely be treated, and sometimes that is quite straightforward and sometimes that's quite difficult, and there are lots of different ways of approaching this. I suppose the main point of this is to say that when we as clinicians working with complex trauma refer to simple trauma or simple PTSD, we do not mean that the PTSD bit is simple, i.e. all the symptoms and the effects, the impact and consequences of that. It's only that we're looking at a sort of one-off event rather than a multiple series of events. And what I thought might be useful today is just sort of going through some of the categories, the 8 kind of symptom clusters of PTSD, just to demonstrate exactly how complicated it can be and how difficult it is for people to actually live with this. So realistically, all I'm going to be looking at here is the sort of the standard DSM-5, the Diagnostic and Statistical Manual for Psychiatric Conditions, the criteria for what we would do if we were looking at diagnosing PTSD. And you can see from this list, just on these 8 different items, exactly how wide-ranging and broad this actually is. And in some of these symptom clusters, there are rules for the criteria, and that comes down to things like, that a person must have experienced one or more of the following for a period of at least a month, taking place after an event that would be considered to be traumatic in nature. So I'll go through these and then sort of put some lists up about sort of identifying exactly the components of this. The first one being what we call criteria A is the sort of exposure criteria. So it's exposure to some sort of event that has a serious or significant nature, might be sort of a risk to life or some sort of extreme violent act. Criteria B is that there has to be sort of a recurrent exposure of aspects that are related to that act, to that event that took place. The third criteria is around avoidance. Again, there has to be persistent avoidance of either aspects of the event or memories or intrusive thoughts related to that event. We then think that there have to be some sort of negative alterations in mood, and this is the fourth criteria. So some sort of change in mood, affect, and those sort of things associated with anything to do with the event. Often what can take place then is the sort of what's called alterations in reactivity. So the way that a person responds or the way that their behavior might change related to an event. The other criteria are more related to things like the degree to which this takes place or how long this goes on for, the level of distress or impairment in functioning or mood or just general sort of everyday life. And that there are no other effects that we could attribute this to. So things like, sort of alcohol or sort of medical physiological events taking place in the person. You can see from this list then that how broad it actually is. And what we'll do is we'll look at the criteria of those things so we can sort of break it down so that there's an understanding. So a lot of the components, as I said, are one or more of the following of these types of things. So a lot of those criteria, the first 5 sets of those criteria, are all broken down into subsections, and what we do when we diagnose is we look to see whether or not those are present with duration and with distress. So the last 3 are applied to the first 5 criteria just to make sure that we are looking at the thing that we think we are looking at. So to start with criteria A, here are the conditions that we'd be looking for, and we're trying to look for one or more of the following of these things that are taking place. So we have things like directly experiencing a traumatic event or witnessing the event as it might occur to other people, learning that the event might have occurred to a close family member or close friend, or that there's some sort of like violent or threatened death or violent event, or experiencing repeated or extreme exposure to aversive details of the event. So what can that mean is that there could be a single event of which there are sort of repeated trigger effects taking place for that event. The second criteria is around those intrusion symptoms, and here's the list of things that we would look to see to try and identify whether these symptoms, one or more of these, might be present. Recurrent, involuntary and intrusive distressing memories of the event, or dreams in which the content of the dream are related to the traumatic event. Any dissociative reactions, i.e. flashbacks, so that feels like the events are sort of taking place again. Intense or prolonged psychological distress, exposure to cues related to the event, or physiological reactions that have cues or triggers that symbolize or resemble an aspect of the traumatic event. So these are quite complex, and it shows how difficult it is to sort of get diagnosis, because we really have to have a deep understanding of the impact of that event, the way that the event manifests in the person's everyday functioning, in their sleep, in terms of their thought processes, their internal moods and their internal sort of beliefs and systems that are taking place around the event. So it really does rely on us getting into that person and their relationship to that event in a very detailed way. The third one, which is about the sort of persistent avoidance of things associated with that event, and we look at the symptom clusters as being like this. Avoidance of or efforts to avoid any distressing memories, thoughts or feelings associated with the event, or to avoid external reminders of the event or anything that arouses distressing memories. So this is like a broad scale avoidance. So the people might actually avoid anything to do with the place. So for example is, let's say if the event was a car crash, they might avoid getting in the car, they might avoid conversations about cars, they might avoid watching television programs in which cars are present, anything that reminds them of that event, and any thoughts about that or any associated moods and feelings about the event are all to be avoided. The fourth one, about the negative alterations in mood, are laid out as follows. Inability to remember important aspects of the event, so some sort of amnesic thing, exaggerated negative or beliefs or expectations about the self related to that. So for example, that might mean that the world is now completely dangerous or everything is ruined. Distorted conditions about the cause or consequences of the event, so self-blame. Persistent negative emotional states, so fear, anger, guilt, shame. Diminished interest or participation in activities, so the loss of interest in doing the normal things. Feelings of detachment or estrangement from others, or persistent inability to experience positive emotions. We can see from this that a traumatic event can have a huge impact in the sense of self, the relation to others, and the relationship to the world. And in dissociated terms, we can see that there are aspects of depersonalization and aspects of derealization occurring within this particular system cluster. But that identity confusion, that sort of the blame, the guilt, the fear, the horror, the sense that everything has changed as a result of that traumatic event is absolutely massive and often crucial to people's being able to recover from PTSD, because it has such a deep effect on the way that a person has believed themselves to be safe in the world, and that is often lost as a result of a single traumatic event. Another example with a car is that a person might drive for 15 or 20 years, believe themselves to be completely safe. They then get into some sort of horrendous car crash and they suddenly believe that the roads are dangerous, the cars are dangerous, they can never get on the roads, they can never get in the car ever again, that their whole life in relation to their car has been completely taken away from them, and that can have a huge impact that can last for years, if not looked after, supported and helped through to recovery. The fifth condition is about the sort of the change in the nature of the person in relation to their behavior. So we call this sort of marked change in reactivity. And the symptom cluster has aspects of it like as follows. Irritable behaviours or angry outbursts, often with no provocation, reckless, self-destructive behaviour, hypervigilance, startle response, problems with concentration, and sleep disturbance. These are the things then that that actually affect the behaviour and the routines and the structure of a person's everyday life. So the PTSD event can really alter the way that the person ordinarily functions, and the things that they may have taken for granted suddenly change, and these are very observable from the outside. So people watching or being with the person with PTSD can see that their behaviour has changed, their mood has changed, and their routines and their ordinary aspects of everyday life are changing, or just the relationship with that person's changing. The sixth criteria is that we're looking for these earlier clusters to the duration has to have taken place for more than a month. And the reason that this is there is because often a lot of this stuff is very, very commonplace following a traumatic event. So a single traumatic event happens, we would expect to see lots of disturbance in mood, in thoughts, in feelings, in dreams, in the behavior, the reactivity, the way that a person remembers or doesn't remember aspects of those dreams. Completely common to take place following trauma. But in order to gain the PTSD diagnosis, these things have to have lasted for more than a month. And the general rule here is that the ordinary process of the healing of the self and the mind and all the behavioral systems do fade after a time. So within weeks of a traumatic event, many people recover quite healthily without any particular help, just ordinary life, getting back to the regular things and overcoming the avoidance and the thoughts and the moods. And for some people that does not happen. It takes much more than a month, and that's where we start thinking about adding in therapy, adding in professional help to assist that person in getting to recovery. And the recovery rates of this with the correct help are very, very good. And then the last two about the significant levels of distress and the sort of all of those things, and that we can't attribute it to any other medical cause. Hopefully then from this list you can see how big it is. There are so many items. It's not just about saying that because a person has experienced a traumatic event and they've kind of been shaken and the things have changed for them, that they've got PTSD. We look at this in a very structured way. We measure the timescales, we look at the impact, we look at all of these different things to gain an understanding of what the PTSD process is. And you can tell from this, nothing about this is simple. So when we are labeling this as simple PTSD, we are simply drawing a difference between this type of PTSD and the complex PTSD, of which the events take place often over many, many years. So, and that shifts the person, and we look at a different set of criteria for that. PTSD is often and nearly always pretty much present within complex PTSD to some form or another, but the layout of it, the way that we look at this is very, very different, and often the dissociative elements become much more observable and much more present. So there is some dissociation within PTSD, but there's a lot more dissociation that takes place within complex PTSD, and that means that the mode of recovery and the treatment pathway are very different. So the guidelines for PTSD and the guidelines for complex PTSD are slightly different things indeed, and it's important to keep those two things separate. And that's why we have the terms such as simple PTSD and complex PTSD. I hope that's made this clear. It's obviously a huge amount of information. It's a lot to get your head around, and this is what we have to do as clinicians sort of working this field, is differentiate all these things, break everything down into these categories, look at the ultimate impact on that person as a unique individual, make some sense out of it, diagnose as required, and then recommend the appropriate treatment pathways. So look forward to hearing your thoughts on this. And I hope this has been a helpful video, just sort of making sense and sort of really breaking down what PTSD actually is. So between now and the next video, please do take great care of yourselves.